I believe we can take it away.
All righty. Welcome everyone to our 35th virtual shadowing session. Today we're joined by a CRNA. Her name is Chrissy and she'll introduce herself shortly. So Chrissy, if you could go to the next slide. Just before we start, these are some upcoming sessions that we have in the coming weeks. On the 2nd, we have history and insights into surgery. The week after that, we're going to talk about legalities in medicine. And that 3rd week in February, we're going to have a specialty spotlight in cardiology with a cardiologist. And be sure to tune in during a live session, and we'll always post a recording of it on YouTube. Chrissy, next slide, please. These are virtual shadowing working group members. We got Reagan, Shayon, Taylor, Alana, Rachel, Miriam, and of course, we have our faculty members, Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno, who's not with us today. Next slide. We'll have 2 Q&A sessions today. There's gonna be one in the middle and one in the end. So be sure to post any questions that you may have in the chat, and we'll sort of curate that, and it'll be answered during those Q&A sessions. As a reminder, please be sure to refrain from asking any questions about the quiz. We'll go into details about the quiz at the end of the session. So if you have any questions on that, just please hold off on that. All righty, and I'll go ahead and give the session over to Chrissy, and she'll introduce herself.
All right.
Chrissy, this is Fowler. Can I just comment real quickly? Firstly, thank you so much for coming, and we're so excited to hear from you tonight. Just want to welcome everybody. Chrissy, you've already got over 700 people just ready to hang on every one of your words. And so we're just so excited. We've had now over 35,000 people sign up for virtual shadowing in over 950 universities in over 28 nations worldwide. So it's a really exciting time. It's so great to have you here, and we're going to keep coming back if you keep coming. So, Chrissy, with that, would you take it away?
All right. Well, thank you for having me, everyone. It's exciting to be here. I wish I didn't know how many people were in the room right now. No, it's okay. All right. So a little bit about me first. I didn't originally know what a nurse anesthetist was. I had no idea I would be a nurse anesthetist. I started out with my Bachelor of Science in Psychology. I minored in biology and Spanish at a small little college called Eastern University. I was leaving the door open to pre-med or pre-PA and kind of got all those classes done, and just started just getting as much experience as I could in different fields. So I got my EMT certification. I did a pre-med internship in Mexico. I studied abroad there for a semester, and I ended up having some of my rotations fall through. I shadowed a physician anesthesiologist down there in Mexico. Only physicians give anesthesia. And I ended up just being fascinated by the specialty. I thought it would be so boring. I just loved how there was such like a human component where Dr. Elia, the doctor that I was paired with, just gave such excellent care to the patients. She just really connected with them on an emotional level, and then also was brilliant. You could just tell that she was brilliant. Everything she did was just, she would explain to me. She just took such excellent care of people and was so wonderful. So that opened my eyes to, wow, this is an interesting profession. Came back to the US, became a nurse's aide in a surgery center to get more direct patient contact experience. And another anesthesiologist took me under his wing there. He would sit out in the pre-op area and kind of, bounce from operating room to operating room while different nurse anesthetists would give the anesthesia in the operating rooms. And so he explained to me what CRNAs were. He would kind of like just talk to me about the medical conditions of the patients when there was downtime. He would bring me into the different operating rooms to let me shadow the different nurse anesthetists. And that's where I discovered the profession of nurse anesthesia. So I finished up my degree early, and I went back for a second Bachelor of Science in Nursing from Thomas Jefferson University. It was an accelerated program. And then I was lucky enough to get a job right away in the ICU at the hospital at the University of Pennsylvania in their cardiac surgery ICU. And I spent less than 2 years there. I was lucky I got into nurse anesthesia school early. I got bumped up a wait list. I was supposed to have another 1.5 to 2 years before I got in, and there was a last minute dropout spot. So I got fast tracked into anesthesia school again at the University of Pennsylvania. And I've been practicing for about 3.5 years as a nurse anesthetist since then. So I've kind of stumbled into this profession, I'd like to say, but it's the best kept secret in medicine. So I'm excited to share it with you all. So what exactly is a CRNA? That stands for Certified Registered Nurse Anesthetist. And believe it or not, they've existed in the United States since as early as the Civil War. So back in the Civil War, there was obviously a lot of wounded soldiers who needed procedures urgently, and not enough surgeons or doctors to tend to them. So the nurses would step up and anesthetize the patients so that the surgeons could perform the surgeries. So that was the first time that nurses were giving anesthesia. And it was also right around the time that anesthesia was first kind of came into routine practice. It kind of all happened around the same time. So since then, nurses have continued to give anesthesia in the US. The first school to ever teach anesthesia in the US was opened in 1919 at St. Vincent's Hospital. It was run by a nurse anesthetist, and it was open to dentists, nurses, and physicians. So all three professions learned anesthesia together and all shared the duty of giving anesthesia in the early 1900s. And since then, it's primarily become a physician and advanced practice nursing specialty, and the two professions, nurse anesthetists and physicians, have been the primary providers of anesthesia in the US since then. Although there are some dentist anesthesiologists that exist, and there is a newer profession called anesthesiologist assistants that exists, but we're not going to talk about them. We're going to get started on the presentation. So why do I love anesthesia? I love that it's direct patient care. Spending time as a nurse has really taught me to appreciate that aspect. I love caring for people. I love that social, emotional component to having a more direct patient relationship. So I feel like anesthesia is a privilege where they get to choose their surgeon and the hospital and research their procedure and WebMD it and Google it, but they don't get to choose you. You are randomly assigned to the patient that day, and you have to win them over in 15 minutes, earn their trust, and explain to them what you're doing to them during the most vulnerable time in their life. And then you get to keep them safe and comfortable throughout their surgical experience. And when you wake them up at the end, people are always so grateful. Wow, I was so nervous. You made me feel so much better. Thank you for getting me through this tough day. So that is my favorite part. I love that you have a direct influence over the surgical experience. The things we do in the operating room can prevent pain, can prevent nausea. We can take a scary day and turn it into a not so scary day. There is an instant gratification component. The blood pressure is low, you give a medicine, you bring it up. It's kind of nice for me personally to have that instant gratification of being able to do an intervention and see an immediate result. We do some hands-on procedures. We intubate, meaning put breathing tubes in people's tracheas or windpipes. Placing arterial lines to monitor live blood pressure readings, placing IVs to give fluids, epidurals to control pain and labor or for a big abdominal surgery. There's a lot of hands-on things that we do. Constantly learning. We have to have continuing education every year, and I'm always learning more. Lots of critical thinking, lots of on your feet thinking. There is a saying in anesthesia, it's 90% boredom, 10% sheer terror. And that is absolutely true. Most of our cases go smooth as glass. You're putting the patient to sleep, you come up with a plan, you execute the plan, and they do fine. But every now and then something crazy happens and you are responsible for fixing it, and seconds count, and you have to react like that. And we're also lucky enough where we get to work with a great team. So you get to know your surgeons, your OR nurses, your surgical technologists. I work in an anesthesia care team model where I work with physician anesthesiologists. So we work really well together as well. And of course, last but not least, I think that anesthesia affords a really good work-life balance, which is important to mention as well. So How does someone become a nurse anesthetist? First, you need your Bachelor of Science in Nursing. You typically need 2 or more years of ICU experience. Some schools will accept 1 year of experience. Typically, it's 1 year before you apply, and it takes another full year to start the program. Every now and then, people have little blips on the radar like me where you get bumped up a wait list. So 1 year at least to start the program, but typically 2 or more. And I got my master's in nurse anesthesia, but now it's moving to a doctorate degree. So by 2022, all schools will have moved to a doctorate degree in nurse anesthesia, and most already have. Most schools will require you to get your critical care registered nurse certification. So that's an exam that you sit for that demonstrates your expertise in critical care. Most schools will want you to take the GRE exam, which you can kind of think is like the SAT for grad school. And they usually want to see that you have some involvement on your unit. So you should usually be involved in at least 1 or 2 committees, like evidence-based practice committees, and possibly doing some research as well. Those are usually helpful to make you more competitive to get in. So what's a typical day for a nurse anesthetist? Our schedules just vary so widely depending on where you work, the type of facility you're in, and what you prefer. So I work in a major academic medical center. I do 3 long shifts. I do 2 13-hour shifts and a 14-hour shift. And that adds up to 40 hours a week. Some people take trauma call and they do 24 hours in-house and then a 16-hour shift. So they work 2 days a week. Some people work 5 8-hour shifts. They just do short days and they come in every day. It really just varies. When you show up that day, every day is different. You are assigned to an operating room, and whatever cases are coming into the operating room are the cases you do. So if you work in a large center that does, 20 different types of cases, it could be one of 20 things. Probably much more than 20, I should say, specialties. You could be one of any 20 specialties. And if you're in a small facility, you might be doing the same thing over and over. So it really, again, just depends. We do all types of anesthesia. So that could be anywhere from OB anesthesia, where you have awake patients getting elective C-sections and placing epidurals, to general anesthesia. That's what most of us think about, where you're going completely to sleep. MAC, monitored anesthesia care, is like that twilight anesthesia where you're sort of asleep, but breathing on your own in like a deep nap. And regional anesthesia, nurse anesthetists also perform nerve blocks, where you numb up an entire portion of the body or extremity and keep the patient more awake, or maybe supplement it for pain control. We place invasive lines like central lines, as I mentioned earlier. You're definitely going to be intubating that day if you're giving general anesthesia. And a lot of times, if you're in a big hospital, you will have to take call. So overnight call involves emergency surgeries and placing airways on the floors or in the intensive care units. Usually the emergency room handles their own airways. There's only been a couple times in my career that I've ever had to go down to an emergency room for help. Usually the emergency docs do that themselves, but once in a blue moon, you might go to an ER. All right, so we're gonna kind of go over an example of the 90% boredom version and then the 10% sheer terror version. And we'll do a question and answer after case study 1, and then we'll do a question and answer after case study 2. So here's our super routine procedure, TURP, transurethral resection of the prostate. So 70-year-old male with BPH, benign prostatic hypertrophy, here to resect it, essentially, to trim away some of that excess tissue because it's blocking urine flow, and that's completely uncomfortable. And typically first people go through medical management, but if that fails, the next step is surgery. So this gentleman has no known drug allergies. His past medical history includes hypertension, coronary artery disease, obstructive sleep apnea, and COPD. So before we go any further, I want to just mention that anesthesia, to come up with a plan for each patient, we're not only thinking about the surgery and what the surgery is doing to the body, we have to come up with a plan to anesthetize for that. But we also have to come up with a plan that takes into account every single patient factor, because the way that you would give anesthesia to me is not the same way that you should give anesthesia to an 80-year-old male, nor is it the same anesthesia that you should give for a 5-year-old female. So we're all going to have different needs based on our size, our age, and our past medical history. So for this gentleman, 2 things I could think of right off the bat: hypertension and coronary artery disease are going to be big red flags in my head, because anesthesia lowers the blood pressure. And whenever someone has chronic high blood pressure, their brains, their heart, their kidneys, all of their organs are used to having a certain pressure to perfuse them. And if you drop that pressure significantly, they're not going to be able to compensate and react quite as well as they would in a young, healthy person who doesn't have that past medical history. So our goal for anesthesia is always to keep the blood pressure within 20% of their baseline. So we want to keep this patient's blood pressure up. Same thing for coronary artery disease. When the arteries that give blood to the heart is a muscle, and the muscle of the heart needs its own blood supply. So when those coronary arteries get really crusty and thick, and you really need a lot of blood pressure in order to give blood to that thick muscle of the heart, especially the left ventricle. So we want to keep that person's blood pressure nice and high. And again, we're giving him anesthesia, so we're going to drop it. So we have to have a plan to counteract that and to be gentle. Otherwise, we could give the patient a heart attack. So two other big things I see right away, big anesthesia red flags: obstructive sleep apnea. Essentially, when a person goes to sleep at night, the soft tissues in their airway collapse and obstruct their breathing. And especially when they're in the supine position, meaning laying flat. So that's a big red flag for us, right? We're going to put him to sleep. We're going to knock out his breathing, and then we're going to try to ventilate with him. We're going to try to get air back in and out of his lungs, and there's going to be tissue blocking the way. So what's our plan for that? Is he going to have an easy airway where I can get around that? Or do I need to come up with a creative plan here? That could be a big deal. And then COPD. So we're going to be putting this man on a ventilator. We have to be very aware of his lung status. Does he have extremely severe COPD where he's on oxygen at home? Is his lung tissue so stretched out and floppy and friable that if we put him on a ventilator and his airway pressures go high, that we could pop his lungs, give him a pneumothorax? Is he going to be able to come off the ventilator easily? We're going to be manipulating this man's airway a lot. So how's that going to go? So all these red flags go off in your head before we even think about the surgery. This is an image of what happens in a TURP. So this resectoscope is essentially inserted through the urethra, and it has like a electrocautery loop that essentially burns away the prostate tissue. So there are going to be some anesthesia implications that come into play with that. All right, so the TURP itself usually lasts about 60 minutes, and we could do the anesthesia in one of two ways. I already gave you a clue that we ended up using general anesthesia for this person, but it can also be done with spinal anesthesia. So a spinal is essentially when we give a one-shot block of numbing medicine, local anesthesia, into the fluid that bathes the spinal cord, and it numbs a person from the nipple line down typically, and it lasts for about 2.5 hours. The reason why we need either a spinal or general anesthesia where the patient's completely asleep and also paralyzed is because, well, let's see, did I get a picture of it? Ah, very nice. The obturator nerve, that big yellow string here, is going to lie right around where they're doing the procedure. So if that electrocautery current stimulates that nerve, it would cause the patient's legs to abruptly adduct and kind of come together. They'd snap their legs shut, and that could cause the person holding the resectoscope, the surgeon, to accidentally perforate the bladder. So we need to be cautious to keep the patient very still by either knocking out their ability to have motor function with the spinal or by temporarily paralyzing them and reversing them. The patient is also in the lithotomy position, which you'll see momentarily, so that will have its own implications. And there's one very big emergency that we have to look out for. Although it's rare, it could be fatal. It's called TURP syndrome. So we'll go over that. Okay. So for airway management of this patient, I already mentioned he had sleep apnea. So he was difficult to ventilate. We put him to sleep with general anesthesia. We paralyzed him. And then the next thing we have to do is get air in and out of his lungs with an oxygen mask before we put the breathing tube in. So I had difficulty ventilating him as we anticipated. So the solution was to pop in an oropharyngeal airway. That's like a little plastic piece here that sits right behind the tongue, pulls the tongue forward, pulls forward all that soft tissue, and allowed us to ventilate easily. So sigh of relief. And then we did a direct laryngoscopy where you take our laryngoscope and we sweep the tongue out of the way, look into the mouth. You can see right between the vocal cords. We had a nice grade 1 view, a nice easy view, and we were able to get the breathing tube in, no problem. So that went very smooth. Next, the patient is, after we secure the tube and make sure his vital signs are stable on the monitor, we begin to position the patient. So the surgeon and usually the resident will put the patient into position, and anesthesia will help hold the airway and also assist in the positioning. So lithotomy position has its own considerations for anesthesia. When you raise the legs of the patient, that holds about 500 mLs of blood volume. So if you have a patient with severe heart failure, you are essentially giving them a temporary fluid bolus. And then when you put down the legs again, you're not actually losing 500 mLs of blood, but it can drop their blood pressure as though they're losing 500 mLs of blood. So you have to be prepared when the legs come down to treat the blood pressure and possibly give a fluid bolus or maybe some medications to bring the blood pressure back up. The devices that hold the legs up also can cause injuries to the nerves if it's like a hard, rigid device. We use like foam booties at my facility to prevent this, but a peroneal nerve injury can cause foot drop. Also, taking a patient who's not used to having their legs up in that high flex position, most people are not that flexible. If you move the legs too abruptly, you can damage the hip flexors. So making sure that both people who are lifting the legs do it at the same time and very gently is very important as well. And one of my big jobs during this time is to watch their fingers, make sure that the fingers don't get caught where those stirrups connect to the bed, because that's right where the patient's fingers are going to go. So we don't want to lose any fingers during a TURP procedure. So making sure they're padded and straight and out of the sight of the surgeon. So blood pressure management, making sure that your patient has, the cardiac stability to handle that dramatic 500 ml increase. That shouldn't affect most patients, only if they're like severely, severely ill. And again, watching out for pressure injuries and so on. So TURP syndrome is our potential intraoperative emergency that could occur. In order to see what they're doing, they're constantly irrigating fluid. And the fluid, in order to make it run in, is running on a tall pole via gravity. And the fluid is usually hypotonic, meaning it has less osmolarity than what a person's blood has. So if we think about, so the reason why they have that is essentially so that the electrical current can conduct. Otherwise, if you have it in an isotonic solution, it can affect how the electrocautery cuts the tissue. So oftentimes surgeons use a glycine solution. The problem is that the patient is at risk for water intoxication. They can absorb all of this fluid through the vascular space in the prostate, as well as through the bladder wall itself, especially if the case goes on very long, if the fluid pull height is very high, and if they don't routinely empty the bladder. So these changes in electrolyte balance can cause a water intoxication. So the patient could get hypertensive from rapid fluid absorption. They could get hypotensive if they develop an acute congestive heart failure, pulmonary edema, cerebral edema. So if you had a patient who had a spinal, you would notice this early on. They would feel nauseous, they'd be disoriented, their mental status would change, a patient could have a seizure. You could see bradycardia, they could become hypoxic. The glycine itself can hemolyze red blood cells. If you were to draw labs, you would see hyponatremia, low sodium levels, and it could also injure the kidneys, and that is from the glycine itself. So this syndrome is fatal. And let's see, did I write it? Here we go. So ways to prevent it. Careful monitoring of fluid in versus fluid out. So it's really important to get to know all the team members that day, learn everyone's names in the room, and rely on your nurses and your surgical technologists to help you keep track of the fluids. Look at the pole, see how much fluid's gone in, and ask the nurses how much has come out. Because if it's not coming out of the patient, it's going into the patient. Making sure that the pole is not too high. And that way we keep the pressure of the irrigation solution low. The surgeons should be frequently draining the bladder on their own, but if for some reason you're noticing a big in versus out problem, you might want to ask or remind them, hey, have you drained the bladder recently? And we want to keep their blood pressure within 20% of baseline to keep that pressure gradient normal. Because if the patient's blood pressure is very low, and then we keep the blood pressure in the bladder and around that vascular bed in the prostate very high, and then we're cutting open that vascular bed, we're going to essentially force fluid in more. So we need to keep our blood pressure up to slow down the rate that we absorb that fluid. And
Chrissy, this is Fowler. Let me interrupt. I wish you could see in chat what people are saying about. One of them just said, "This is the most in-depth educational shadowing that I've been able to listen to yet. Thank you for being an amazing teacher." I just wanted
thank
you.
you.
Well, thank you so much. Please keep going.
Oh my gosh, thank you. I feel I'm so flattered. That's always my goal.
Wait, but another one just asked, are the surgeons rude to you?
Sometimes. I keep them in their place, don't worry.
Oh,
No. The key is always communication and developing a good team dynamic early. So anytime you enter the workforce in life, right? It's true in school, it's true in families, it's true everywhere you go. There's always a rude person, right? The key in the operating room, the thing is, the patient's on the table, patient safety is number one. We don't have time for attitudes. We don't have time to have communication inhibited by bad attitudes or being afraid of each other. So for me, the best thing I can do that morning is establish open lines of communication. So my name is Chrissy. I'm the nurse anesthetist today. What's your name? How do you like to be addressed? Okay, let me know if there's anything specific that you like. Once we open up that conversation, even the rudest of people, it always melts away. And, I think we all have the same goal, right? We all want to get through the day smoothly, and we all want to be on the same plane and keep the patient safe. So open lines of communication.
That's right.
All right. So how do we treat TURP syndrome? Oh my God, my patient has TURP syndrome. They had a spinal, and I could see that their mental status is changing. They're under general anesthesia. They're suddenly hypotensive, bradycardic. I drew a blood gas, and oh my gosh, their sodium is so low. I think they have TURP syndrome. What now? Tell the surgeon right away so they can either stop the procedure or finish it quickly. We might want to give Lasix to help them flush out all that fluid, make them urinate, get them back to normal, send off labs immediately. We want to see what's going on. You may want to start hypertonic saline. So they've been absorbing this solution that's hypoosmotic. We need to, or hypotonic, I should say. Now we need a hypertonic solution to kind of balance them out and slowly get them back to normal, especially if they're experiencing cerebral edema. We want to gently return them back to a normal state. And of course, maintain their airway, because it's very likely at this point that this patient could develop an acute congestive heart failure or pulmonary edema. So if your patient's not intubated at that point, let's say you did a spinal, it might be worthwhile to consider intubating them, or perhaps even doing some sort of a CPAP or BiPAP to give positive pressure to, how do I explain this in like layman's terms? That positive pressure that you put in the airway can sort of decrease that preload and decrease the fluid coming into the heart so that we're not overloading their heart and lungs all at once with fluid. So finding some sort of an airway solution there if they're getting fluid volume overload in the chest or in the heart. So how did this case go? It went fine. It was uneventful. It was a normal day. This patient did great. The surgery was under 60 minutes. I did this exact procedure 2 weeks ago. It was absolutely fine. It was general anesthesia. It went well. At the end of the case, we woke him up. We took out the breathing tube. He sat in the recovery area for 30 minutes, and then he went about his day. It was absolutely fine. So that's the 90% boredom, right? Anesthesia is a lot of anticipation and planning. What could go wrong? How do I stop it from going wrong? And then nothing goes wrong. It's great. So that is kind of our goal here. So we'll stop here and do a quick Q&A, and then we'll do a 10% sheer terror case study.
Chrissy, let me start. We had a question. We've already had like 200 questions. And we got a couple dozen for you. How do you get your labs back so quick if you have a guy that you think may be hyponatremic in the OR? Do you have like iStats or something where you can get quick lab turnaround?
Yeah, we do have. It's just like an iStat. Actually, I'm not sure what the brand of our machine is, but yeah, we could draw a venous blood gas or an arterial blood gas, and that'll give us the hemoglobin, the sodium, the potassium, the calcium, the glucose. What else does it give? The pH, oxygen, carbon dioxide. So you get the basics right there. And then, our stat lab, if we needed more electrolyte levels, which we wouldn't for that situation, but if you were to need more electrolyte levels, you could always get a turnaround time from the real lab But yes, we have an iStat right outside the OR.
So when you're there in the OR, where there probably is almost no closer contact to someone that you're having to put under a pharmacologic sedation of some sort, but the case may take several hours. It's possible to get lulled, I don't know, into the humdrum heartbeat on the monitor there. How do you keep your sharpness moment to moment during
Yeah,
hours of
I
surgeries?
I think that everyone has their own way of doing it. One of the first things you learn in anesthesia training is the sweep. So we're monitoring so many things at once, right? Not just the patient's vital signs, but also the surgery and so many things going on. So I'm constantly sweeping. And then in between my sweeps, I check on the surgery and see what's going on. So or I guess I should say I make that part of my sweep. And that's kind of how I stay entertained, honestly. I look at the monitor, I read every single vital sign. I look at my anesthesia gas or infusions, whichever one I'm using. I look at my flow rates, and then I move on to urine output, blood loss. Okay, look over the drapes. What's going on in the surgery? And then I look at my pumps, and then you do the whole thing all over again, and you just keep doing it over and over for hours. I think that for me, because I'm a nerd, watching the surgery itself and learning about the surgery is entertainment enough, right? I can think that most people here can probably relate to that. If you're here tonight on your spare time watching a virtual shadowing session talking about cases, you could probably relate to the idea that it's interesting to watch cases. So, that's part of my job, is to understand the surgery. So I watch it, I ask questions, I talk to the surgeons, and I'm always learning it. It makes me a better anesthetist. So I think that just staying involved in what's happening in the room is like a good mental stimulation. Um, that's kind of like the best
We're,
way
we're
I
having,
recommend.
we're having lots of questions being asked by the students this evening regarding the training that you got for this job, and we'll come to some on CRNA versus anesthesiologist.
Mm.
But you're describing a very close attention sensation of the patient and all of the patient's physical parameters that can be monitored. How long did it take you to get that kind of sixth sense?
Yeah, I think that the one thing that makes nurse anesthetists able to do this job is the fact that we have critical care nursing experience. And I think that before I became a nurse, I didn't fully appreciate the responsibility of nurses or what nurses did. And it wasn't until I worked in an ICU that I fully understood like how much further training critical care nursing is outside of nursing school. So when you work in an ICU, you have to monitor and manage every single aspect of the patient around the clock. Of course, physicians are available, but you're the one who's in the room with the patient all the time, and the physicians are busy with other patients. And so you have a close working relationship where when you sense something's wrong, you call them and they come and assess with you. So you have to know how to assess your patient so you pick up on issues early. That's the role of the nurse. So I think that having that foundation and then bringing it into anesthesia helps you develop a sense of something's wrong. It helps you develop a sense of thoroughness, attention to detail, and kind of helps you know what to prioritize. And then when you learn the more in-depth physiology, the more in-depth pharmacology, the anesthetic implications in the classroom and then in your clinical sites, that's when it kind of all comes together. But it definitely takes all of the years. I think a lot of people ask if they can kind of rush the ICU portion, and I say no, like that is the thing that allows us to do what we do.
Oh, just wonderful. Ani, take it away, please.
Oh, a lot of wonderful questions. There's a lot of questions that people have been asking about the differences between a CRNA and anesthesiologists.
Everybody's favorite question.
Favorite question.
Yeah. So just from an education, well, I guess I'll tell you the education, then I'll tell you the role differences. And it's hard to answer because it varies depending on where you work. But from an education standpoint, quick review: CRNA, Bachelor of Science in Nursing, typically 2 or more years in an ICU. And then your master's or doctorate in nurse anesthesia. Those programs are about 3 years long. Those programs, you're spending 40 to 50 hours a week in an operating room. And you're also taking, graduate level pathophysiology, pharmacology courses that just go a little bit deeper than what you had in nursing school to kind of catch you up on what you missed. Then the physician anesthesiologist, I think most of us know how that goes, right? You go to medical school And then you do an anesthesia residency. So, 4 years of an undergraduate degree, take the MCAT, 4 years of medical school. And then, of course, anesthesia residency is 4 years total. Your first year is your intern year. You do either a year in internal medicine or a year in surgery. And then you do 3 years in the operating room to train as an anesthesiologist. After that, you could go on and do a fellowship for another year to do critical care, regional, pediatric, some sort of subspecialty if you want. But to become a regular anesthesiologist, it's the 3 years in the OR. So as far as the role differences, it's going to really depend on where you work. I work in a major academic medical center, so we have very clearly defined roles. The way that most large centers work is a medical direction model. That's a billing term that's written by CMS, the Centers for Medicare and Medicaid Services. And essentially what they say is that in order for us to both bill for the case, the physician anesthesiologist has to fulfill 10 basic steps called the TEFRA rules, and has to show that they were there for all the critical portions of the case. So they have to take part in the preoperative exam. So we'll both examine the patient. We both take medical histories. And then they have to be there for induction, which is one of the more high risk parts of the case. Think about like taking off an airplane, right? So they have to be there for induction. They have to be there for emergence. They don't have to be in the room necessarily, like when the breathing tube is coming out, but they need to check on the patient around that time period. They have to, at some point in the case, say that they were available to monitor. So they have to pop into the room at least one time. And they can oversee up to 4 operating rooms at once and bill this way. So 4 ORs, a CRNA in each room. If they have a resident in the room or a student nurse anesthetist, they can only do 2 rooms at once. And then I'll be in the case the whole time from start to finish. So I'm the person who is doing the procedures and physically caring for the patient. And then my anesthesiologist, they're my teammate, right? If I need help, if I have a question, if an emergency comes up, we're in there together doing the things. There are CRNAs who work independently. In the US military, CRNAs work completely independently, in which case their job will look exactly like a physician anesthesiologist. They're used interchangeably there. In rural hospitals, typically they're independent practicing nurse anesthetists. So that'll look just like a physician anesthesiologist. And then in most suburban, like mid-sized hospitals, maybe there's like kind of a blend of like different roles. Sometimes they do medical supervision where the doctor will have up to 8 rooms. Sometimes the doctors will care directly for the patient one day and other days supervise. It's usually kind of a blend. So I can't give you a clearly defined answer there. It really depends on where you work. But I guess the best way to, again, summarize is we can be in teams where one person is supervising, overseeing, bouncing room to room, or we can kind of be interchangeable. It just depends on where you are.
Wow, thank you so much for that detailed answer. I think you covered a lot of the I guess doubts that everyone had between those two sort of similar yet distinct.
Yeah, we overlap so much, you know?
Yeah. And there was actually a follow-up question that kind of goes well with that first question. But this person was asking, what's the benefit of having both physicians and nurses be experts in administering anesthesia? Like, what's the benefit of having that model, which we don't often see in maybe other specialties?
Yeah, so I guess I can come up with kind of 2 answers. I don't think that this system was designed intentionally. In fact, I know it wasn't. It kind of just developed historically, right? The nurses kind of stepped in the Civil War and have been giving anesthesia since then. And then physicians also kind of were like, hey, like, let's do this too. And then both professions kind of developed like almost parallel to each other. And so some facilities use physicians and some facilities use nurse anesthetists. And sometimes we interchanged. And it's kind of like this strange haphazard history that is very murky. Now the anesthesia care team model, I think, has been a little bit more thoughtfully implemented in the large centers, where the idea is that these patients are really complex and they are really sick, and anesthesia is very high risk. It seems very simple, but even if it's a straightforward procedure, just the act of giving someone sedation alone can kill them. So it is nice to have, people with 2 different perspectives, 2 types of experts caring for you. It's nice that one person, in the room the whole time and another person on backup. I think it makes it safer for the patient to have extra hands around. And And I think having the different perspectives is helpful, but I'm biased because I'm a nurse anesthetist and I work with physicians. So I guess I see the best of both worlds there. So yeah, I guess it's just, it wasn't designed this way, but I think we found a way to make it work to the benefit of the patient.
Wow. Thank you for sharing your perspective on that. And another really good question is what's a good personality trait that makes a good CRNA, or what type of personality makes a good CRNA in your opinion?
I think you have to be a good team player. We've talked about like challenging personalities in the OR. We've talked about how you have to be very thorough and ready to handle emergencies. I think you have to be, again, just a good team player, pay attention to details and keep lines of communication open. It doesn't help anyone to be prideful or to be a know-it-all and say, I got this. Like, someone's life is on the line there, right? So if you have a smidge of doubt in your mind, just ask the question, ask the surgeon, ask your anesthesiologist, phone a friend. I think that you need to be willing to kind of just be humble and constantly learn and ask.
Awesome. That could across a lot of different professions, really. But thank you for sharing that. Another good question is, what did you find was the best method to comfort patients who are sort of nervous or anxious about undergoing anesthesiology or anesthesia? Have you ever had an encounter where a patient was sort of wary of going under anesthesia?
Yeah, every patient, right? It's the scariest time in someone's life. And again, I think a lot of times the anesthesia is an afterthought. People kind of prepare for all these things and they get to you and they get wide-eyed. They're like, it's time for the anesthesia. You're the only person they don't get to pick. So you have to approach it from a place of compassion and empathy. I think it really helps to explain everything in plain language and only make promises that you can keep. So there's very few promises you can keep in medicine. One promise that I know I can always keep is that I will explain to you every step of the way and answer any questions you have. That's the promise that I make. And I think once people know that there's no surprises, that we're going to talk everything out the whole way, a sense of calm comes over their face. Letting them know what to expect. And then when the things happen that I tell them that they will expect, I think they regain a sense of control of the day, a little bit more understanding of what's going on. So putting people kind of back in control of an out of control situation. We also get to cheat. We have medicines that do that, right? Midazolam is a great medication. It's not appropriate for every patient, but we can cheat. We can slip people some medication that will help take the edge off if they're really over the top, if they're really just not feeling comfortable. So a mix of, therapeutic communication and pharmacology.
Awesome. And there was another question where this person was having trouble finding or trouble shadowing CRNAs. And this is going back to the crisis we have with COVID right now, where hospitals don't allow students, to just walk in and observe healthcare professionals. So what's your advice for those trying to prepare for CRNA schools, outside of physical shadowing and internships?
Yeah. So one tip that I didn't know as a nurse. So if you're already a nurse working in a hospital, sometimes a way to work around this is to directly email your department of anesthesia. So your chief anesthesiologist, your chief CRNA, you can email them directly and ask. Sometimes it's a little bit easier to get in that way. Also, if you're in the process of actively applying to CRNA schools and you don't have these opportunities, you can contact the school directly. Sometimes the people who work at the school have a connection that they know is allowing shadows. And then, of course, you could ask about if they'll accept virtual shadowing or like directly interviewing a CRNA. I'm a resource you could always go to if you need to like talk to me directly. This is my 4th virtual shadowing session that I'm now going to be part of that I'll keep links to. So you could use those. And then, I think that, and there's a Facebook group called ICU Dreaming About Anesthesia, I.C.U Dreaming About Anesthesia. And it's run by a nurse anesthetist in the Midwest, Jenny. She's in Ohio, I believe. And they offer more like virtual shadowing opportunities as well. So I would, again, talk to your anesthesia department first and talk to the school that you're applying to, and they can usually figure out a plan with you.
Awesome.
Chrissy, I wish you could see the number of people who are saying, Chrissy, be my mentor.
Oh my gosh. I'm trying.
And one last question, I guess, before we move on with the rest of your presentation. But we have a lot of PAs that are in our program, and they want to know how PAs fit specifically into the field of anesthesia, or is it only for CRNAs and physicians?
So that's a complicated question. So there is a separate profession called anesthesiologist assistant that people often compare to PAs, but it's its own 2 years of schooling. So it's set up like PA school in the sense that after your 4 degrees of your 4 years of undergraduate and your pre-PA courses or pre-med courses, then you take either like a GRE, or sometimes they want you to take the MCAT or the PCAT. And then they have you apply to these anesthesiologist assistant programs. They're 2 years long. It's a master's degree. And then you would operate in a model like a CRNA that is in medical direction. So AAs can't work independently because they work under a physician license. There's no APRN license for them. So that's more similar to a PA. And unfortunately, they only work in 18 states in the US. So they're only in the South pretty much, mostly Florida and Georgia. In the state of Georgia, AAs are technically under the PA license. So they're legally somehow grouped in with PAs only in Georgia though. But for a PA, typically that would mean like going back for like more, like you would have to get another master's degree in anesthesia if you're a PA. There is no current option for PAs to just subspecialize in the way that they can kind of bounce to other fields.
Awesome. Thank you so much for sharing. And we'll have more questions later, but if you like, you can sort of continue on from where you left off, and we'll get to those later.
Do it. All right, let me get this chat out of here. Okay. So our case study 2. This is the 10% sheer terror. So this happened to me a few weeks ago. I changed, in both of these cases, these are based on real cases that happened to me just in the last few weeks. But I changed a lot of the patient information so that they would not be identifiable. So this is a little bit simplified of their medical history, but here we go. So this is a 60-year-old male who came into the emergency department and presented with some bleeding around his tracheostomy. So that's what I was told. I was told, hey, we have an emergency case coming into your room. This guy has an existing trach. There's bleeding around it. The ENT surgeons, they're going to take a look and see if they can stop the bleeding. He lost some blood in the emergency room, but they packed it and he's fine. He's stable. That's what I was told. No known drug allergies. History of high blood pressure, coronary artery disease. Again, what's our goal here? Keep the blood pressure up. He's a former smoker, and he has a history of tonsillar cancer, status post-TORS. That's a transoral robotic surgery. Transoral robotic surgery. So with the robot, they go in and they resect the cancer around the tonsil, the base of the tongue, and so on. He had a radical neck dissection as well, which is a very big surgery. They will take down tissue all throughout the neck and remove the lymph nodes in the neck, because it's very hard to tell if which lymph nodes the cancer spread to. So they take out that lymph node chain. They're operating around a lot of major blood vessels. We know our carotid arteries there. We know our jugular veins there. So they're going all around that and trying very carefully to remove a ton of muscle tissue, and leave all of that intact. And he also had radiation to that area. So these are huge anesthesia red flags. The airway has been messed with, ding, ding, ding. And radiation, it causes scarring. It causes the tissue to be very friable. It's essentially burning them, right? So big anesthesia red flags going off here. So when we found out a little bit more, when he came up to the OR, surprise, there was a lot more to the story than I was initially told. Apparently, he was very hypotensive in the ED, very low blood pressure, had a low hemoglobin, a lot of blood loss. Hemoglobin is 6, very low. It should be closer to 14, 15, 16. They ended up giving him 2 units of Packer blood cells and 2 units of fresh frozen plasma, and they were still currently trickling in. And he came up with a lot of access. He came up with a arterial line in his groin and a central line in his groin, and all his blood products hanging, and all these vasoactive infusions running. That's another red flag. Why do we need so many vasopressors to keep this man's blood pressure up? And like I said, they had packed his throat, which is another big red flag. Ooh, I was told there's a little bleeding around the trach. Why did we need to stuff packing all the way into his throat to stop the bleeding? Is there something more going on? This seems a little sketchy. So he came up with a cooler of blood, all these pressors running, and all these lines going. When you hear about an emergency case like this and it comes to the operating room that fast, that's a big red flag. Something's going on. If things can wait, usually we'll take our time, we'll get more information, we'll set up. The fact that we got the phone call and he showed up 5 minutes later, big red flag. So here is a picture of, oh, it's a little blurry, a patient post radical neck dissection. So you can see her right side, our left side, if we're looking straight on at the photo, a lot of her muscle tissue was resected. She might have had some post-radiation changes as well. See how that like tissue looks kind of like stretched out and thin. So that's essentially what this patient presented with. And he also had a tracheostomy in place that he had placed along the way afterwards as part of the sequelae of his disease course. So it turns out that what this gentleman had was a carotid blowout. So a carotid blowout is a rare but very serious complication of head and neck surgery, especially if combined with radiation. So from the study I found, it was they kind of sorted through a lot of different studies of carotid blowout, and they found that the rate was anywhere from 4.5% to 21% of all patients with head and neck surgery combined with radiation. It's rapidly fatal. Overall mortality is 76%, and that includes cases that are identified early and even before they happen. So once a patient actively is bleeding from the carotid, it's almost always fatal. Initial management, wound packing and pressure. So that's what our docs had done in the emergency department. They put a bunch of gauzes essentially in there to kind of put pressure on it from the inside out. I don't think that they were sure at first that it was, I'm not really sure. You know, it all happened so fast. I'm not sure if they were 100% sure that it was a carotid blowout right away. I think they were kind of being proactive. So we took him up to the OR I think they were attempting to do direct surgical management. They were hoping from the inside out they could just cauterize it a little bit and move on their way. But that did not end up being the case. So let's just look at the anatomy a little bit more. Here is our carotid artery. It brings blood flow all the way up to our brain. That is, of course, extremely important. And it bifurcates, it splits into the external and internal carotid arteries. And most carotid blowouts occur around the level of the bifurcation. And that is what happened to our gentleman. So for our initial management, I already mentioned he came up with an arterial line that's really important for live blood pressure reading. That way we know exactly what's going on with him second to second. Large bore IVs are very important for a patient like this because we're gonna have to get blood products and fluids in fast. Unfortunately, he had extremely poor venous access. Most of his IVs that he came up with blew. He had an intraosseous that I forgot to put in the PowerPoint, but those you can get medications through, but they don't really run freely. They're hard to get large volumes in at once. He did have a central line in, but it was a triple lumen, which if you're familiar with them, if you work in critical care or the emergency department, triple lumens are very, very small in diameter. So they're not easy to give large volumes through. We ended up having to place a second groin central line that was bigger to give volume through because we couldn't get to the neck and he didn't have good veins in his arms or his legs. Even though we had multiple members of the anesthesia team looking with ultrasound at every extremity. He came up with 4 vasoactive infusions: norepinephrine, epinephrine, vasopressin, and phenylephrine. And anyone who works in the hospital knows when someone's quadruple press, that is a big deal. We are essentially artificially squeezing everything they have to try to keep their blood pressure up, but that's a sign that something is drastically wrong. He already had blood products dripping in from the emergency department. So we started finishing them up right away, started checking the blood products in the cooler to hang more, and instantly sent off labs. So what happens the second the surgeons remove the packing? He instantly exsanguinates, just blood everywhere. I cannot tell you how much blood this man lost. I couldn't even guess. Well over a liter within seconds. Instantly, his heart stopped. So we had to begin a code. So anesthesia's role during a code is we are the team leader, at least initially until more help can come. So notify the surgeons in the room, he's arresting, the OR nurse gets on compressions right away. Or if there's a resident available, whoever is available first gets on compressions right away. So I think it was actually our resident started compressions and our OR nurse called for help. The charge operating room nurse comes in with the code cart and they take over the role of reading off our ACLS checklist. And helping us stay organized and on time and checking the clock, making sure that every 2 minutes we pause compressions to check for a pulse and so on. We called for anesthesia stat overhead. So a swarm of CRNAs and anesthesiologists came into the room, began working on access, looking for more lines with the ultrasound, taking turns doing compressions, pushing medications, and recording and documenting as well as checking blood. We aggressively replaced his blood volume as the surgical team held external pressure to his carotid artery and began again repacking to stop the blood. And we were able to stabilize him. So after just a few minutes of CPR and resuscitating, we got him back. And we made the decision to call the interventional radiology suite and see if we could attempt an endovascular repair downstairs. So meaning they would go up through a line through either his radial artery or femoral artery and kind of try to sneak into the carotid from the inside out and either glue it or coil it or stent it, whatever they could do to stop the bleed from the inside out. So that was kind of the plan. The problem was, since the tissue was compromised from the outside as well as the inside, every time the resident let go of the neck, the patient would re-exsanguinate. So the residents had to take turns holding external pressure to the neck until the repair was complete. So over the course of 7 hours, they took turns continuously holding pressure on this person's neck. Real quick, let's just talk about this. Essentially became a trauma resuscitation, right? So principles of resuscitation in a massive transfusion. This was called the trauma triad of death. Whenever somebody has a severe blood loss, we worry about this triad. So hypothermia, a cold patient, can lead to poor platelet function. It makes them bleed more. They have a hard time clotting. As they become coagulopathic, they have a harder time clotting. They bleed even more. As they bleed more, they lose perfusion or blood or oxygen to their vital organs. So as the organs get starved of oxygen and blood, they create lactic acid, just like after a really tough workout, right? You get sore muscles. All your organs are doing that. So the increased acid worsens the coagulopathy even further, and it's a vicious cycle that goes on and on. So, the three things we need to do are to maintain a normal blood pressure. We don't want it to be too high because we don't want to worsen the bleeding out. So permissive hypotension, but still enough pressure to give blood to the organs. We need to keep them warm as best we can. So we heat the room and we heat the patient. In our trauma rooms, we heat them to 80, 90 degrees. We become very swampy and sweaty. And we try to aggressively replace with blood rather than like normal saline, for example, because we don't want to dilute out those clotting factors. So, there we go. Management for large blood loss, get help and assign roles immediately. So you want to use your OR nurses, whatever anesthesia help comes in the room, assign someone to just check blood. You need 2 people to check blood, get people checking blood, get 1 person just documenting. 1 person should just be managing the rapid infuser if you have enough help. Somebody can be giving medication, sending labs, just overseeing things. You want to call the blood bank, activate massive transfusion protocol so the blood bank knows to keep things going. You, again, want to minimize crystalloids. We don't want to dilute out all those wonderful platelets and clotting factors that we're giving back. And we want to replace blood in a 1-to-1-to-1 ratio. So for every unit of blood, we want to give a unit of plasma and a unit of platelets. That way we're not giving only blood, and forgetting to give back clotting factors. I mentioned permissive hypotension. So again, you could imagine if you have a stab wound that's wide open and bleeding out, or a gunshot wound, or a ruptured carotid artery, if the blood pressure is high, you're just going to lose blood faster. But we also can't have it too low, right? We need blood to get to the brain and the kidneys and the heart and all those things. So permissive hypotension, for this patient, a systolic of 90 was perfect. 90 to 100 was my goal for him, because with him losing so much blood from his carotid artery, I was concerned about him getting enough blood to his brain. When you have one side completely clamped off, you're depending on the entire brain to get perfused through something called the circle of Willis, which I think I have a picture of coming up later. And yeah, keeping his pH normal via adequate perfusion, doing everything we could. That's a picture of our rapid infuser that gets blood in super quickly, faster than gravity, faster than squeezing it. The machine kind of squeezes in the blood. And here's the circle of Willis. So that's in your brain. This is what allows, not everyone has an intact circle of Willis. So if you lose blood flow from one of your carotid arteries, you can get blood flow from the other side if this is intact, if this little circle is intact, blood flow from the right side to the brain to the left side of the brain and so on. But not every person has this intact. So typically if you have a side clamped off, like for any sort of a carotid artery surgery or an emergency like this, we would want the blood pressure to be very, very, very high to allow blood flow to come from the opposite side. But we were in a little bit of a pickle here since he was losing blood externally. So here was our little Grey's Anatomy moment of the day. This is a picture from a Canadian television show, but it was very close to what happened in real life. So since the residents had to hold pressure on the external carotid artery, they had to ride down in the stretcher with the patient from the operating room to IR, which is down an elevator down the hall. So they were in the bed with the patient holding pressure, which was pretty crazy. I was very impressed. They did a very good job that day. And this is a picture of what happens in an interventional radiology suite. So this is a picture of someone else's endovascular treatment from the Journal of Neurointerventional Surgery. But essentially on the left, you can see an aneurysmal carotid artery, and right around the bifurcation is a big old aneurysm. That's why it's all balloony looking. And then on the right, it looks like they stented it off. So this isn't exactly how our patients looked, but the idea is that through coils and glue, they can essentially correct or repair it. Our team was able to repair it, but unfortunately they had to glue off, I believe, the external carotid. And after so many hours of essentially clamping off his artery, we expected there to be some sort of neurologic deficit after the procedure. Another interesting thing that went on was, in order for them to get in there and do their interventions, the residents would have to continuously let go of the artery in order for them to physically get in from the inside out. And every time the residents would let go, the patient would re-exsanguinate. So we redid a massive transfusion protocol on and off for 7 hours. So I had different people rotating in to help me at different times. A mix of anesthesia residents, nurse anesthetists, and attending anesthesiologists would just come in and take turns just helping me squeeze blood and check blood for 7 hours. It was a long day. So at the end, after they finished the procedure, we went to the SICU, the surgical ICU, and we had given over 40 units of blood product. I was very excited about this. On our patient's blood gas in the ICU, his acid-base balance was in normal limits. His hemoglobin was 10, which is not normal, but pretty darn good, pretty compatible with life. It's often our threshold goal for critically ill patients. His electrolytes were normal. His airway pressures were stable, which is a huge deal when you do a massive resuscitation. These patients are at a huge risk for fluid volume overload, circulatory overload in the heart and lungs, pulmonary edema. So to have good airway stability and airway pressures is an awesome win. Normal urine output means that we did a really good job perfusing his kidneys, which means we did a pretty good job perfusing his brain. His vital signs were completely stable, and he was on 0 vasopressors. So he came up on 4 and we got them all turned off. And the next morning he woke up and followed commands. So we were able to perfuse his brain adequately over that time against all odds. Now, I will say this, he still, he had a massive neurologic deficit. So he was able to wake up and follow commands, which was nothing short of miraculous. But he did have a complete right-sided stroke. He had aphasia, and he was not able to move the left side of his body. So it was certainly not a perfect outcome, but it was the best possible outcome considering his carotid artery was clamped for 7 hours on and off. And they actually were able to see on imaging that he did not have an intact circle of Willis. So so that was our case. So that was our 10% sheer terror. Yeah, let's do another Q&A.
Chrissy, one of the questions that just popped up says, what has been one of the hardest moments you faced as a CRNA? This sounds like one of those.
You know what's funny is that I wouldn't even say this one is one of the most physically exhausting days I've had in a very long time. But I think when you have a situation where you're given impossible odds and you have a best possible outcome despite them, that's a lot easier to digest than when something should go well and then doesn't against your expectations, right? Like if you have a very healthy, stable patient and then an unexpected emergency happens, that's a lot more devastating and challenging to deal with than, your train wreck patient who you're just trying to keep alive. So I think that is the hardest. I think when you have emergencies in OB specifically, so many people in anesthesia will go, oh, I hate OB. They don't really hate OB. They hate the anxiety of the responsibility of taking a young, healthy woman and a baby and having the risk involved with the things that could go wrong. So those are the days that are the most challenging, but they're rare.
Chrissy, do you do anesthesia on all types of surgeries, or is there a certain area that is your area of expertise?
Yeah, so I do everything except for, I don't do hearts right now and I don't do OB right now. Next year, I'm hoping to get on our heart team. So we'll see. Did a lot of hearts in school. And I did a lot of OB in school, but we are not currently doing OB. But next year we'll be doing OB as soon as our new hospital opens. So that will be fun to go back to.
What do you think was your greatest weakness when you were entering this field, and how did you overcome it? Or did you have weaknesses? Because you had a ICU background, right?
Well, of course I had weaknesses. I would say my biggest weakness, I think I've always been very afraid of, you can be very afraid to mess up. You can be almost like too afraid, right? So you have to sort of challenge that into a healthy fear. I think that is like one very big thing to overcome, like the stress and like the pressure of putting on yourself of perfection. You don't want to tunnel vision into perfection so much that, you are, again, afraid to ask for help or maybe lack confidence in yourself. When you know the answer, but you're afraid of, feeling dumb. So you just say, I don't know. I think that one of the hardest things is to kind of just like channel like normal fear into a healthy fear.
Chrissy, several folks have asked specifically, they said, my heart pounds and I get terrified. Do you ever get used to this? And I think part of it is questioning. I think part of it is questioning yourself. But what did you find over time? I mean, in the ICU, you took care of sick patients, so you were very accustomed to critical illness.
Yeah, I think that I'm going to flash back to my first year as an ICU nurse. It was the hardest year of my life. Not to get too personal, but my sister passed away 2 weeks before I started in the ICU of an aortic dissection. And then my first ICU job was on a cardiac surgery ICU where a lot of our patients had fresh aortic dissections or sometimes dissected right in front of us. So it was hard to have the pressure of taking care of such critical ill people, and then also have it feel so personal to me, and then also be very new and feel very underprepared for it. So that anxiety, that heart pounding feeling just made me absolutely nauseous. I was nauseous every day before going into work because I put so much pressure on myself to keep everyone alive and to fix everyone, right? One of the greatest tasks in maturing through your medical education, no matter what profession you're in, is to know what your limits are, learn what's in our control, what's not in our control, and to prepare ahead so that when, things happen, you do know what to do. You take a deep breath and you have a little bit of faith in yourself. You know when to utilize your team appropriately. And to also realize what things are out of your control. So, for example, with our carotid blowout patient, I can't control the fact that this man had a stroke. There's no way around the fact that he was going to have a stroke. But I was able to control, my knowledge of trauma resuscitation, working in a trauma center. That's something that we study and prepare for and practice routinely. I know when to ask for help. As soon as this man started bleeding, you call for anesthesia stat. There's no hero in the situation. You get help right away. So, knowing your limits, preparing ahead, and knowing when to just take the burden off of yourself of you can't save the day all the time.
Several of the students have asked, so in this setting of crisis in the OR, does everybody know their job, or do certain people have to be assigned to certain urgent critical tasks?
I think a little bit of both. So I think a lot of times you'll see this in ICUs. Actually, ERs are better about this than the ICUs are in the OR. But I think when emergencies happen, there tends to be like a million people rushing into the room and everyone wants to help. And then no one knows what anyone's job is. It gets very murky. So having someone delegate roles to people. So that was my job when everyone came in for the first anesthesia stat. You help me check blood. You find vascular access. You get the code card, you start compressions. Like giving everyone a role right away helps keep things clearer.
Having the 870 students who've been watching you tonight, Chrissy, listen to how someone went from being a really young person and then becoming a nurse and then becoming an ICU nurse and then stepping gradually into this job of being a CRNA, taking care of astonishingly potentially sick or actually sick people, and that how you can be so calm and so decisive about how these decisions are made. How did you learn that? Did you buy it in a box of Rice Krispies? I mean, where did you learn that?
I wish. Wouldn't that be nice? A lot of practice and preparation, right? I think that one of the biggest tools and one of the best things we're really getting so much better at in education is simulation, right? I remember when I was a nursing student, like high-tech sim labs were like a new thing, and we were terrible at using it. They put us in sim labs and nobody even knew how to use the sim lab, and I learned nothing. And then when I went to nurse anesthesia school, sim lab had like become a little bit more involved, and we had some amazing simulations, and they totally prepared me for this. I actually had a carotid blowout simulation. And so when it came in real life, I remembered it from school. I was like, oh my gosh, I know what to do. In pediatric hospitals, they do mock codes all the time. We do them a little bit in the adult world, but not nearly as much as the pediatric hospitals do. So I think that like the reading ahead, but also simulating ahead and talking out, hey, if this emergency goes wrong, like this is what we're going to do. I do that whenever I have a high risk case. I talk about it with the team. Hey guys, if this emergency goes down, this is where my stuff is. Like, I'm going to ask you to grab it for me. So preparing ahead is what helps me stay calm.
Chrissy, we were talking before we started about how, I've been in medicine nearly 50 years, and the change that we've seen in technology these many years. And one of the questions one of the students asked is, what do you anticipate may be ongoing technological advances in your line of work in anesthesia?
Oh, I think artificial intelligence is going to drastically change anesthesia in the next 50 years for sure. There already is a machine called the SET-Assist that exists in Europe, which is AI that measures effect site concentration of the anesthetic drug. So it's not even just measuring drug levels in the bloodstream, it's measuring like the concentration at the receptor sites. I don't even know how it does it, wizardry. And it will adjust automatically the infusion pumps to the correct level of medication for that patient. Now it's used only for like conscious sedation MAC cases with propofol infusions. It's not for all of the anesthetics at this point in time. But I think we're going to see a lot more of that. I think we're going to see artificial intelligence automatically adjusting our anesthetic levels for the patient. We'll still be responsible for watching them, right? Things can still go wrong. You'll still need a human to place lines and do procedures. So it's not like our job is going away, but I think there's going to be more of a shift towards relying on these AI algorithms. So it's going to be really important when training people who grow up in that era to be able to rely on the ways without the computer as well, because there are times when there's computer failures or power outages, or you work in a a hospital without resources, and they won't be able to have that. So it's going to be a challenge to train people to do traditional anesthesia as well as artificial intelligence anesthesia, I think.
I think there's no question. And I don't even call it artificial intelligence anymore. It's assisted intelligence. I wish we had an AI platform built into our Epic medical record so that, as we're going through a complex differential diagnosis, for example, that the machine could be helping us think. We had a case recently at one of our conferences of a patient that came in with a dissecting aortic aneurysm. And by the way, several people wanted to offer their condolences about your sister.
Oh, thank you.
And that people didn't think about it, and I remember what William Osler said, not personally, but I read about it, that he said, diseases of the great vessels make humble men of proud physicians because you can't think of everything. And that's where I was getting back to the AI thing. Medicine is so vast and so complicated that having, computers run at the speed of light, and having intellectual assistance that can help us in diagnosis and decision making, especially in times of emergency, will be quite helpful in the future. So I hope that you're right about that, and we'll see more of that come. I've seen that, and as Gil Salazar, in ultrasound in emergency medicine, how we didn't use it when I was a kid. Now, of course, we use it constantly in our work in the emergency department. Ani, I'm sorry to get in your way. I know you've got a bunch of questions, and please go ahead.
No, it's no problem, Dr. Fowler. And we do have a lot of questions. If Chrissy, if you're willing to answer some of those. So this person asked, were you always good with talking with people, or was that something that you had to learn as you went through your schooling and became a CRNA? And they mentioned how you're so confident and well articulated. And I have to agree with that.
Thank you. I appreciate hearing that. I would say a combination of, I think I've always had good basic people skills. And I think that comes from my upbringing with my sister. So she had Turner syndrome and autism, and you have to have a lot of patience and understanding and just kind of like emotional intelligence when your only sibling has a communication barrier with you. I think that was, just a huge part of, I guess, the way I communicate. But also learning that on the job is huge. So when you first are a nursing student or a medical student or any sort of student in the healthcare field, you're going to have to learn that the way you talk to your friends or even in a classroom is very different than how you talk to patients. When a person is very afraid and you're trying to take complicated concepts and break them down into plain language, and you don't want to you have this burden where you want to comfort them emotionally, but you don't want to overpromise things, or you don't want to brush off their concerns either, or it can be really hard to walk that line. And unfortunately, it's a little bit of trial and error and a lot of observation. So I always recommend to anyone who's interested in healthcare, CRNA, PA, MP, MD, whatever you want to do, to get your foot in the door as either a nurse's aide, a patient care technician, an EMT, something along the way before you hit school, so that you become comfortable talking to patients and observing other medical providers communicate with patients and learn to model what you do after them. And take the things you like from other people and take note of the things you don't like and make a mental note not to do those things. And eventually you develop that skill over time. But the earlier you start, the better. And it also looks great on the resume.
Yeah, and that's a really wonderful advice. Thank you so much for sharing that and your story as well. Another question that someone wanted to know is, how would you describe your transition from becoming a nurse to a provider as a CRNA? And to sort of add on to that, I know nursing has a lot to do. Bedside manner is a big integral part of nursing, as is with every sort of healthcare professional job. But this is especially true for nursing. So how did that sort of change once you became a CRNA?
Yeah, that was probably one of the toughest transitions in school, is going from, your role as a nurse is to sort of be like the eyes, ears, hands, and feet of the team. So you're like the hub of the wheel, where you're communicating with respiratory therapy, the doctors, the specialists, the nutrition team. Like, everyone's kind of communicating with you, and you're relaying info, and you're assessing, and you're monitoring, and you're calling back. And that's kind of your role there, right? And then performing any interventions that are ordered. So you're doing a little bit of all that. When you go into a provider role, you have to step back from trying to be the ultimate task manager. You have to let the nurses do the nurse's job now. But B, taking on the authority of like, oh, this is my decision now. It's kind of shocking when you first hear the people in the room say like, oh, well, what do you want? What do you mean, what do I want? What do you want? So that can be kind of a hard transition and mindset change. Fortunately, in my training, I feel like the CRNAs who taught me did a really great job of modeling and encouraging me, and helping me feel confident. And we took a lot of call. And when you're on call overnight as a student, we would be alone in the room. The physician anesthesiologist would be kind of like popping in and out, let us do our thing, and kind of treat us like the CRNA. And then our CRNA would be in bed asleep, and we would like only call them if, the place lit on fire. So that sort of practice of like being the mock provider, and having that long leash of responsibility helps kind of break you out of that mindset. You have to, now act like the CRNA.
Yeah, that is that is a great sort of adjustment that you got to make. Thank you for sharing that. Has there ever been a time where you faced a problem or a dilemma that you had to overcome at work, and how did you resolve this?
Oh, that's tough. I
Sorry
mean,
if I sound like an interviewer right now.
oh my,
Nothing to do with it.
ooh, that's a challenging question to answer. Um, One of my favorite things about the CRNA program I went to was we had this thing at the end called Speaking Up. And it was in one of our courses right before we graduated. Our professor came up with this idea to help us prepare for the real world. We were just kind of in a time where we were done with our real curriculum, we were studying for boards. And so we did these speaking up exercises where they came up with really tough real life scenarios. And they made us take turns getting up in front of the classroom and acting out how we would deal with them. And when I got into practice, some of those things happened in real life. So I don't want to get too into detail because this is going to be, on the internet. But, having some challenging professional issues where maybe someone who's in a position of authority over you is maybe not necessarily doing what's right for the patient, and you have to speak up and you have that power difference. So practicing for that scenario kind of set me up to know the right thing to do and feel bold in doing the right thing. So I, was a new CRNA when this happened to me, and I immediately took it up the chain. I just emailed my chief CRNA. I emailed my chief anesthesiologist safety officer. And I just said look, this is what this person did today, and I didn't feel comfortable with it. And I'm letting you know because this was not okay. And it was immediately addressed, and I got the full support of the staff, and it was handled appropriately through all the professional channels. So that was pretty cool to feel backed up. But it was scary, right? When you have a power difference and you're the new person, it can be really hard to do that.
Awesome. You've been giving out a lot of great nuggets. I've mentally recorded it in my mind. Just keep it at the back of my mind. Thank you so much. This question is more on the personal side, but how do you maintain a healthy work-life balance? I know you sort of touched up on that briefly in your presentation, but if you wanted to elaborate on that.
I think it's not so bad now as a CRNA because I work 3 long shifts. So I just keep my work days and my life days my life days. And I try not to accept too much overtime or per diem because working more can get very addicting when you have student loans and you can make so much more at your overtime rate or your per diem rate. It's very easy to get sucked into that. And I think it's really important for me personally to set aside time for myself. And that way I can be fresh for my real job and also, fresh for my family and for myself. So I think having like a healthy boundary with work. When I was in school, that was almost impossible. We had just so much time. I was in the OR for 50 hours a week. The DMP programs are a little more spread out. They're probably in the OR for only about 40 hours a week, but at least 50 hours a week, plus, 4 to 5 classes at once and constantly studying for cases. I made a rule on Friday nights, no studying at all. So after I got home from the OR on Friday, no studying. And on Saturdays, like once it hit dinner time, no more studying. So no more studying after 5 p.m. on a Saturday. And Sundays, I could go back to studying again, but I had like 9 o'clock study cutoffs every night of the week. I had to go to bed. No more studying after 9 o'clock at night. So I think like having rules for yourself to carve out like time to breathe is really important.
What's your favorite surgery that you've been involved in? Do you have like a favorite type of surgeon or specialty or field that you'd like to operate in?
I really like variety. So I like that at my job, I do a little bit of everything. I think I would get bored if I did any one type of surgery all the time. But one of my favorite specialties is plastics because it's so fascinating to me. Like plastic surgery is such a very broad field. It can encompass so many types of surgery and so many types of body parts. And oftentimes it's not just cosmetic, it's often reconstructive. So you can take someone who had burns before or like traumatic injuries or whatever it was, major weight loss, whatever you can come up with, and reconstructing. And so sometimes it's for a just a cosmetic reason. Sometimes it's for like a physical quality of life reason. Either way, I think it's like fascinating to watch that type of procedure, and I think it's cool that we have surgeons who can do that. I think that's a really big deal, and they're pleasant patients to work with usually because a lot of times they've been through a lot. At least the types of plastics I do, because I'm in an academic center, right? So these patients have usually been through a lot of trauma and like and multiple surgeries. So taking like kind of like their bad experience and then having like a more positive outcome is like kind of a nice thing to be a part of. A lot of these patients had like large cancer resection. So it feels like kind of just bringing a sense of normalcy back to someone. So I think it's kind of nice to watch that process.
Awesome. And sort of before I forget to mention this, but I want to share some of the comments that you've been receiving throughout today or this session today. But one comment said, "Chrissy, you've charmed us all. We love you, Chrissy." Someone else said that you're the epitome of a great teacher, and I couldn't agree more.
Oh, thanks, guys.
But yeah, and Dr. Salazar, I know that you haven't been able to ask a question yet. So if you had any questions that you wanted to sort of ask as well, feel free to unmute and interrupt me.
No worries. Thank you, Ani. Thank you, Chrissy. It's been a phenomenal session. I want to ask you about your experience about being a woman, a female in the workplace, especially in an environment in surgery that has traditionally been dominated by males. Thankfully, we've seen a big shift in that. I just want to kind of get your opinion about how things are shifting.
Wow, that is a really good question. I've noticed a huge shift since the time I became a nurse till now, and even a shift from when I started my nurse anesthesia school training to like now that I'm practicing, which not that many years ago. I started my training in 2015. So there were still a lot of issues in the surgical world of really bizarre things that you would think would be a thing of the past, like sexual harassment was like actually pretty common. And you'd be like essentially kind of like expected to sweep that under the rug or like ignore that. And like maybe your evaluation would depend on you ignoring that or like being willing to like joke like the boys, which is like so crazy to me. It feels like that was so many years ago. Again, our program was really good at telling us like, hey, if people are being inappropriate with you, like let us know and we'll take them down. But some of my friends had some pretty inappropriate experiences happen to them. I didn't have anything too crazy happen to me, fortunately. But that culture was tolerated. And ever since the Me Too movement, it's definitely not. Also, more female physicians entering the workforce has completely shifted the culture of medicine, I would say. Like having like a gender balance shift from like nursing being all women and physicians being all men to like more men entering nursing, more women entering the field. I feel like it's really broken up those strange gender dynamics and has really like kind of helped that new era of like looking at things as more of a team than a hierarchy. And it's just making the workplace like a lot more dynamic and positive. You know, I don't think, I don't know. It's not like, oh, all male doctors are bad or please don't take me wrong. Don't think I'm saying that by any means. But I just think kind of like breaking up those traditions has helped benefit everyone overall.
Wonderful. Chrissy, if you wanted to go on to the next slide, just to talk about the quiz real quick. So this is the information for the quiz. It's going to be due by next Tuesday. The deadline is going to be right before the session, or next week's session. So all you have to do is go to the website and enter the PIN exactly as it is with the dashes and the password's right there. And you'll have a week to do it. And Dr. Salazar, I know you had an announcement as well to make about VCOP. So if you wanted to make that now.
Yeah, for sure. Thank you. It'll be pretty brief. Remember that our first session is going to be February 4th at 7 p.m. Central. We're going to open the registration and payment later on this week. And remember, it's $29.99 for the entire program to help us pay for the platform, etc. So that's going to be good. On our website, www.vcop.ws, there's some more information in there, and we have this scholarship for option for some of you who may have significant financial difficulties. Please go ahead and fill it out. It's going to be a case-by-case basis. We're happy to accommodate you. We're going to be doing some other cool stuff outside of our regular sessions. We're considering a VCOP session in Spanish for our friends from Spanish-speaking countries, and other sessions on CPR, some tourniquet use, etc., some emergency procedures. So that's going to be fun. And as always, you can always look me up on Insta. I post almost daily content. So looking forward to having you guys there.
Wow, Chrissy, what a wonderful session. I want everybody to please put "thank you, Chrissy" into chat, and Chrissy, turn your eye to the chat just so you can see 600 of our closest friends telling you how much they love you, and
Thank you, everyone.
and an outpouring of gratitude from all these pre-health kids who are going to be following in your path one day. Chrissy, just to let you know, we will have probably 5,000 people who will go over this lecture. That's typically how many go over each one of our lectures on the website. There was nearly 1,000 live tonight. Each one of those healthcare providers will probably see 100,000 patients in her or his career. 5,000 times 100,000 is 500 million. Tonight, with your wonderful charm and your sweet demeanor and your amazing training, you've touched 500 million lives down the road. So thank you for contributing all of this and so much more to our students. And on behalf of the working group of virtual shadowing, we just thank you so much.
Thank you so much for having me. I'm so grateful. This is such a great conversation to have with everyone.
Oh, yes. Well, everybody, thank you for coming. This has been another great session. We're going to be here as long as you keep coming back. So if we need to be doing shadowing online, we'll be here. So we may be doing a survey of just a few questions to see what sort of things you want to have covered and all that sort of thing. And you may be getting a note from us through the website. On behalf of the working group of virtual shadowing, Dr. Salazar and myself, on behalf of Chrissy and the wonderful lecture she gave tonight, we want to thank you all for coming, and we wish you a good evening. Good night.
Thank you so much, Chris.